Okay. Good evening and welcome everyone. Thank you for joining the Canadian Celiac Association's webinar, Diagnosis and Treatment of Celiac Disease in Children. This is a Growing Up Celiac Education series, which is generously supported by Glutino and Udi's Gluten-Free. I am Gauri Bawa, registered dietitian on the client support desk for the Canadian Celiac Association, and I am joined here today with Melissa Secord, the executive director of the CCA, and our presenter for the evening, Dr. Dominica, who is a pediatric gastroenterologist, along with the representatives of Udi's Gluten-Free and Glutino. For many of you joining us today, you may be confused or overwhelmed with the amount of information that diagnosis and treatment of celiac disease, especially with our little children, as well as our young adults. Our plan is to walk you through and learn more about the diagnosis and treatment of the celiac disease so as to assist you in planning the pathway towards better outcomes. As I said earlier, this is a webinar supported by the Growing Up Celiac. We have a workbook which is now also available in French. At the end of this webinar today, I will be sending out a copy of this workbook free to everyone. This is especially for children and parents to understand. Children love reading this book. So I will send you an English version. You want a French version, you can always go on to the website www.celiac.ca and sign up for a free copy in any language you want, English or French. It is generously supported by Glutinos. The Canadian Celiac Association is a small national charity, and for nearly 50 years, it has been led by volunteers and experts as a source of evidence-based information and peer support. We advance advocacy on key issues such as safe food and labeling, delivering education programs and services, and invest in research to empower those living with celiac disease and gluten disorders. This education, like I said, has been generously supported by our gold partners, Udi's Gluten-Free and Glutino. Udi's motto: eat well, smile often. The mission of Udi's Gluten-Free is to show you a new way to approach gluten-free living. Udi believes everyone should be able to eat a sandwich or a hearty and a delicious bagel, or indulge in a cheesy slice of pizza, even if you are gluten intolerant or have celiac disease. And they don't stop there. Udi's realizes the varying degree of food allergies, and that's why they've created delicious varieties of baked goods that are also dairy-free, soy-free, and nut-free. Dig in. And Glutino. There are a billion and one companies out there making you choose between gluten-free food and flavorful food. Now, that's not fair. But for Glutino, there is never a distinction to begin with. Delicious gluten-free snacks aren't something that Glutino has cooked up. They have been perfecting in them for over 20 years. And as long as people love delicious food, they don't intend to stop. So dig in: crackers, pretzel, cookies, wafers, loaves, English muffins, and now I'm hungry. Oh, wow. Before going forward, just a quick reminder: an upcoming event from the Canadian Celiac Association. Our national virtual conference, completely free. Remember the date, note the time, and sign up. The date is Sunday, November 15th. The starting time is 12 noon. Lots of researchers, lots of doctors, lots of professionals in this field coming forward to share their knowledge, the new expertise, the new happenings, the new research, the education. To learn more, just visit www.ccaconference.ca. Remember again, the name: Expanding Your Horizons, our virtual conference for the second one this year. Gluten Free 101 is a webinar that is hosted every month. It is free. It is run by me and some of our students and volunteers who put in their amazing time with us to help you. It is supported by SHAR, and we are thankful to them too. Dr. Dominica, our presenter for the evening. Thank you for joining us here. Dr. Dominica is a pediatric gastroenterologist practicing in Calgary, Alberta. She has clinical and research interests in celiac disease. Recent studies have included investigating the use of serological criteria for the diagnosis of celiac disease in children and exploring the rate of celiac disease in the first degree relatives. She's a member of the Professional Advisory Council for the Canadian Celiac Association, and her support means a lot. Before I hand over the stage to Dr. Dominica, just a few things I'd like to review about the webinar. All participants are muted so that everyone can enjoy the session with minimal disruptions. If you have a question for our presenter, please type them in the question and answer box and we will get to them in the end. I apologize in advance if we cannot get to some of your questions. You can email us with your questions at info@celiac.ca and we would be happy to respond. There is a chat box available to chat between yourselves. However, please do not ask any questions in the chat box because we intend to download all the questions from the question and answer box later and see how we can help you out better with them. This session is recorded, so if you would like to review the material on tonight's session, we will email you a copy of the recording along with the PowerPoint slides. Now, the floor is all yours, Dr. Dominica. Welcome.
Gauri, thank you so much for the introduction. Okay, I'm going to share my screen. Oh. Perfect. Here we go. Okay. Okay. Can everybody see that? And you can hear me as well. Okay, so thank you so much for that very nice introduction. So what I wanted to do for the first maybe 25 minutes of the presentation is to go over some of the basis of diagnosis and then treatment in children. For the treatment part, I'll focus more so on some of the nutritional factors that I think about in the children, talk about symptom resolution and following up their serology. And then for the diagnosis, will also talk about some understanding about genetics, our serology that we do, and then some of the children we biopsy, others we apply a serologic diagnosis. So I'll talk about a little bit of that, and then there might be some questions sort of how things were done during the pandemic and the postponement of some of those elective procedures that we couldn't do over the spring. So I wanted to go over this slide first. It's a bit of a busy slide, but I like to go over it with my patients because it helps to understand what is happening at the intestinal level in a patient with celiac disease. And really the beauty about celiac is we know what the autoantigen is, it's TTG. We know what's driving that process is the gliadin. So this has been very nicely illustrated. So firstly, when you ingest gluten, which is shown in this image in sort of the string of the longer green beads, that gets broken down by our human enzymes into gliadin. And as humans, we cannot break gliadin down much further, any further than that. Now, that gliadin then is able to go through the intestinal cells or in between them. And so these are intestinal cells here. And as the gliadin goes into past the intestinal cells, it gets modified by the tissue transglutaminase enzyme. So it's an enzyme that we have. And this is, in fact, when we measure our celiac screen, we're measuring an antibody to this enzyme. This enzyme is released by these damaged cells, and we're measuring an antibody to that. So when the TTG modifies the gliadin, it becomes this deaminated gliadin, which in this picture is the little red ovals. And then this binds to a cell in our immune system called the antigen presenting cell. These are cells that present things to our immune system to say, well, is this something you should be worried about? And so it presents this modified gliadin and deaminated gliadin through these receptors. And I wanted to highlight this because this is the receptor when we talk about genetic testing. We're testing this HLA-DQ2 or DQ8 receptor. There's a variety of them in humans, and in particular, we know that patients with celiac have one of those too. So the deaminated gliadin binds very tightly to this receptor. It then stimulates the T cell receptor on this side, and then that stimulated T cell releases all sorts of cytokines, which then result in the flattening of the villi and the increased white blood cells that we see. And also the T cells then recruit other immune cells, such as B cells, and make more other antibodies. And one of those is the EMA, the anti-endometrial antibody. And one of the reasons I like to show this picture to my patients as well is I explain to them that if you stop eating gluten here at the top, then this whole process here quiets down. But these T cells are always hanging out, and they're ready to attack if they get this tight binding with the diamidate-gliadin. So this is why at this point the only treatment for celiac disease is a lifelong gluten-free diet, because we do not yet understand how to turn these T cells off so they stop reacting to gluten. So I sort of talked about the genetics, and celiac has a very, very strong hereditary component. When we looked at identical twins, monozygotic ones, 75%, if one has celiac disease, 75% chance the other one will. And when it comes to fraternal twins, it's about a 10% prevalence, which is very similar to what we quote for siblings. And as I showed you in that previous diagram, really the best characterized genetic susceptibility for celiac are these HLA, DQ2, and DQ8 markers, where over 99% of patients with celiac are positive for one of them or both of them. It's important to understand, though, that also the general population is positive for HLA-DQ2, about 30%, and a smaller number is positive for DQ8. So having the genetics isn't enough to have celiac, because 30% of the general population, in fact, carry the genetics for celiac disease. And when you look at the genetic prevalence in first-degree relatives, 80% of them carry the HLA DQ2 or DQ8. So I sometimes find it helpful to measure the genetics in relatives, but oftentimes I do explain to the family that very likely you're statistically very likely to be positive for one of those genetic markers. So what we learned from this, from the genetic studies, is that genetics are very necessary to develop celiac, but they're not enough, because 30% of the population have the genetics. So it's obviously not enough to have only the genetics. There are also some other genes that people have explored, and we know that there are environmental factors. And when we refer to the environmental factors, more and more research is looking at the microbiome, which is the bacteria that we carry in our intestines, and how that interacts with our immune system. So in terms of doing a serology testing for celiac disease, the total IgA and the IgA TTG are the best tests for detection of celiac disease at any age. We used to previously say that you had to be over 2 years of age to do the TTG, but in fact now we know that if your total IgA is sufficient enough, then the TTG is the best test. So if a patient has a low IgA test, then there's a different type of celiac screen that can be done. And one thing to just know, so for example, here in Alberta and Calgary, our lab would automatically do an IgG TTG if the IgA was low. That's automatic. In some places, though, the physician may need to order a total IgA and an IgA TTG to know what those are. So that may be lab dependent. The other thing to know is that there is intertest and interlaboratory variability for the TTG. And what I mean by that is there are really tens of different types of TTG kits out there. We in fact have a different one in Calgary than they use in Edmonton, different one in Vancouver. So each of them perform differently. You also can't compare the numbers directly between tests. And also, more importantly, certain tests perform a little bit more accurately than others. And I think most of the big labs know that. And but that's why in general, when physicians look at TTGs often, they understand sort of how that value correlates to what an endoscopy might look like. So that's kind of the important part about TTGs. And also, if you happen to be moving, know that probably the other lab is going to have a different normal value, for example. It's really important that the person is eating gluten when you do a celiac screen. And we usually recommend a minimum of 2 portions of gluten a day. And if you want to get more information about the gluten challenge, there's a document on the CCA website about that to help patients navigate how to perform a gluten challenge. The TTG really reflects the intestinal damage quite well, and it predicts how severe the duodenum is affected by celiac disease. So for that reason, if a patient has a really low TTG, oftentimes that means they may not have very much um, uh, changes in their duodenum secondary to celiac. That usually correlates pretty well. It's an excellent test. It's really reliable and pretty inexpensive as well, so a great screening test. And I think what's really worth noting is that it can have some false positive and false negatives. So by false positives, I mean that the test is positive, but the patient doesn't have celiac disease. And some of the cases, for example, are if the patient has any other autoimmune conditions. So conditions such as type 1 diabetes can often cause a low positive TTG, for example. And in fact, the endoscopy would not show celiac. And other false positives, if you have any infection in your intestine that might cause sort of a bit of an inflammation that could then lead to a false positive TTG. And false negatives, one I already mentioned, if the patient's not eating enough gluten, the TTG could be negative. Secondly, if the patient has a low IgA level, then the TTG would not be a reliable test and could be actually falsely negative. So those are some of the big considerations that I think about when interpreting a TTG test. I wanted to mention a study that was done, this is an Italian study, just to highlight that not every child with a positive celiac screen has celiac disease, and that's important to know and not just automatically start a gluten-free diet. So this was a study done in 280 children. And they followed those children for up to 9 years. So it was quite an impressive long follow-up study. And so each of those children had 2 positive TTGs. Then they had an intestinal biopsy that was normal. So that was what you needed to have to enroll in the study. 2 positive TTGs, normal intestinal biopsy. And they followed them for the 9-year periods, and they repeated they all ate gluten, and they repeated their celiac screen about every 6 months and their duodenal biopsies every 2 years. And what they found was that about 32% of the children actually completely normalized their celiac screen and never developed celiac disease. They only had, for a period of time, a positive serology. So I highlight this study because it's really important that if somebody has a celiac screen, that they speak to a gastroenterologist who's familiar with this to then decide, is it an appropriate time right now to do an endoscopy, or and how should the patient move forward, and not just automatically start a gluten-free diet, because it's not always the case that the patient has celiac disease, and the study was a good one to demonstrate that. Just briefly about an endoscopy. So it's a very common procedure that we do as gastroenterologists. In pediatrics, at my center, all the children are under anesthesia, so they're asleep. And it's not because the procedure's particularly painful at all. It's simply because as you try to pass the scope, a patient would gag, and so you actually couldn't get very much done. So the endoscopy, the anesthesia is to relax the muscles, and so that patient's still. And the endoscope looks like a long black cord. On the end of it is a camera. So there's a flat screen TV that the doctor is seeing what they're doing. And then through the channel, you can pass like little forceps that you can take tissue samples with. So you would go down the esophagus into the stomach, and then usually for celiac disease, we see the changes in this very first part of the small intestine. That's called the duodenum. And this is quite a straightforward procedure, usually takes about 15 minutes to do, and then the patient wakes up and goes home that same day. And so these are some pictures of what on the left a normal bowel would look like. So in your bowel, you have these villi, and there are these like finger-like projections. I usually describe them to my pediatric patients like Nemo swimming through the anemone. So they allow you to increase your absorptive surface area. You can absorb lots of nutrients because you have all this places to absorb. And then a patient with celiac disease, the villi are flat. Now, sometimes they're totally flat, like in this picture, and sometimes they're a little flat. So there's a bit of a grading scale for that. And here's a representative endoscopic picture of what it might look like. So you see like these bitten out chunks here, that's called scalloping. The tissue almost looks like, I describe it almost like the Arizona desert. It just looks cracked and dry because all the villi are flat. So oftentimes when a gastroenterologist performs an endoscopy on a patient where they're suspecting celiac, you will look for some of these visual features, so you can let the patient know, does it look like there's some features of celiac visually, and then they take biopsies through the endoscope, and they send those biopsies to the pathologist, who then looks under the microscope to see if the villi look flat and if there's inflammation. And so this picture really nicely shows, sort of the top here illustrates what the different grading scales for the duodenal biopsies. So on the left here is the normal biopsies where the villi are nice and tall, and on the far right here, there's all these inflammatory cells here, all these white blood cells. The villi are flat, and the pathologist sometimes graded according to Marsh criteria. Other pathologists sort of describe each of the features of what they see. So that's why we look to see that any changes, and we also take biopsies because that's what the pathologists are looking for. And so some of you may be familiar that it was in 2012 that the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition first published guidelines presenting that in some children it may be possible to make a diagnosis of celiac disease simply based on a few criteria without going forward with a biopsy. So the children should have symptoms and signs of celiac disease. So various abdominal pain symptoms, diarrhea, maybe anemia, joint symptoms. So it's outlined there. They need to have a TTG that's very significantly elevated, and this stands for upper limit of normal. And the reason it's written that way is because every lab has a different normal value, so that the test has to be 10 times the normal value. And then also they should have a positive anti-endomysial antibody. And many labs perform this test, maybe not every lab. And then the initial publication also requested that the patients have this genetic testing. These guidelines were just recently revised in 2019, and the genetic testing is no longer part of the criteria. And the reason for that is really, if you met all three of the first three criteria, adding the genetic testing really wasn't changing the diagnosis. You already knew the patient has celiac disease. It wasn't adding very much more. And there's even more data now saying some patients, if their celiac serology, TTG, and EMA are very high, even if they don't have symptoms, you could discuss with them whether they would be interested in a serologic diagnosis. So here are the criteria that were first published in 2012. The references are here, and then they were revised in 2019. So I always have a discussion with my patients if they meet this criteria. Some patients are very relieved to find out that they do not need to undergo a biopsy to confirm that they have celiac, because I'm already very 100% certain. And other families still opt to have the biopsy even if they meet these criteria. So it's very family dependent and individual specific. And then the important thing is that the patient must be monitored to make sure that they improve on a gluten-free diet, and their blood work should be followed too. So that's the other sort of really important part of applying this criteria, is that the patient should be followed to see how they're doing. And so the next part, I wanted to go through some important issues that I make sure to discuss with my patients when I do see them and follow up in the clinic. So talking about some of the nutritional factors that I think about, talking about their symptoms, the blood work, and when I follow that, and then also screening for some of the other conditions that we know can be associated with celiac. So I tell my patients that when you have to remove a whole food group like gluten and wheat, rye, barley, that it's so important you eat a variety of other foods. And so I talk to them about the fact that the gluten-free diet many of the foods are not fortified in B vitamins or zinc, so they should go on a multivitamin. Some of the patients, if they eat a lot of green vegetables or other very nuts and variety of beans, possibly have enough B vitamins and zinc in them. But oftentimes, especially in pediatrics and some of my picky eaters, I suggest starting a multivitamin. Also, I mentioned that the gluten-free flours aren't always fortified with folate. They can be low in fiber, especially if the patient's eating a lot of rice flour. Sometimes when a patient is first diagnosed and their villi are completely flat, they actually might have transient lactose intolerance. So we talk about whether they want to try lactose-free, but we also make sure that they eat enough calcium. And I live in Calgary, and basically it's getting dark, starting 7:30 now. So I say, listen, our winters are 6 months long. They're dark. You should definitely be on a vitamin D supplement. It's really important. And then there's been a lot of really good studies showing that the processed gluten-free foods can be high in simple sugars and fats, and that's even especially important in my patients with type 1 diabetes, that they don't eat too many simple sugars. I talk about constipation a lot in my clinic. Constipation is just very common in kids, and it can be also common in young kids with celiac if they're not eating enough fiber. So we talk about the fact that they need to eat enough fiber. The rule of thumb is about 5 grams of fiber per year of life, sort of 25 grams generally up to that level. This is actually, there's a handout on the Alberta Health Services website, which anybody can access. So if you go to albertahealthservices.ca, there's a fiber and a gluten-free diet handout. So I just really go through and make sure that they eat a variety of fiber, because a lot of my patients might eat, let's say, Chex cereal that's gluten-free, but can be low in fiber. They'll have white rice and potatoes, and then they don't maybe eat other things like quinoa, brown rice, flaxseed, chia seeds. So we really talk about constipation. Some of the kids present with constipation at the time of diagnosis. Some of them get it after starting gluten-free diet. It can cause a lot of stomach pain. So then you're also wondering, is the stomach pain new because they're still getting gluten? So that's why it's a common thing that we discuss. I mentioned already that vitamin D is important, and it's important for bone health. We know that patients at the time of diagnosis, their bone health is often a bit inferior to their peers, especially in pediatrics. We know that they can recover quickly, their bones, after they go gluten-free. About a third of adults at the time of diagnosis of celiac disease have osteoporosis, and the other third of osteopenia. So bone health is really, really important. And the reason the bones are suffering at the time, when the patient has active celiac, is because all those inflammatory proteins in the intestine actually cause calcium to leach out of the bones. So the first one is going gluten-free really helps restore your bone health. I talk about getting enough calcium in the diet, and if they can't tolerate dairy, lactose, for example, if they're lactose intolerant, we talk about still having lactose-free milk or yogurts or other foods to get enough calcium, or supplement. I check their vitamin D level once. Right around wintertime, I usually check it to see what it is going into winter. I typically recommend starting 1,000 units, and then if the vitamin D level is really low, then I might adjust that. Obviously, exercising, that helps promote healthy bones. And I do not often do a bone mineral density in children. Even in adults, it's usually reserved for those adults who presented with a lot of weight loss and diarrhea. But I do order this bone mineral density in my teenage patients, for example, who are not really adhering to the gluten-free diet. I might sort of try to show them how, in other ways, their body is suffering by their intestines not yet being healed. A common, not super common, but common enough that a question that comes up in follow-up is they might still have symptoms. And so the first question is, could there be gluten exposure that's contributing to ongoing symptoms? It is usually the most common reason. So I have a dietitian review the diet history quite carefully, and then I often check the celiac screen. I think the big caveat with the celiac screen is if somebody had a cookie yesterday and did the blood work today, unlikely would the celiac screen change much. It's because it's an antibody we're measuring. It will not respond within a day. But if a patient is eating regular amounts of gluten several times a week, then I will see a change in their celiac screen. So if somebody spent somewhere in the summertime for a week and got gluten, and now we're doing blood work end of September, when they're back on their gluten-free diet, I may not see as much of a change. So that's one thing to understand, is that the celiac screen was really designed for us to diagnose patients. It wasn't specifically, it's not as good at following patients to see after they go gluten-free. It is really the only test we have, but we need to understand its limitations. If a patient still has symptoms, I wonder if there's something else going on. So we talked about lactose intolerance, because that can present with diarrhea, gassiness, bloating, abdominal cramping. Some patients can have small intestinal bacterial overgrowth, again, bloating or diarrhea. Microscopic colitis is a condition that's associated with celiac. It's not very common in children at all, but it can present with lots of diarrhea, very watery diarrhea. And again, more often in adults, but a consideration if a patient still is very symptomatic with diarrhea. I think about if they could have developed another autoimmune condition, so maybe Crohn's, I would screen for blood work. And then you wonder if there could be irritable bowel syndrome. And we do know that children with irritable bowel syndrome have a higher prevalence of celiac, and the flip side, that even patients with celiac who are strictly sticking to their gluten-free diet, about 30% of them had irritable bowel syndrome symptoms. So I think about all those different factors when I have a patient in the clinic who's still reporting symptoms. This was a study that I did a few years ago, and it was just looking at how quickly the celiac serology drops after going gluten-free. Now, these were all patients that we sort of followed. We went back in their charts, and so they all reported to us they were strictly gluten-free. And we had 3 categories of patients. The black line was the ones who had super, super high TTGs and EMAs. They'd be the ones you'd probably do a serologic diagnosis. The gray group was still very high TTGs and moderately elevated EMAs, and then the hashed lines were the group that had negative EMAs and a mildly positive TTG. And what I remind my patients is, if you started super, super high at the time of diagnosis with your blood work, at about 22 months, 50% of the patients had normal TTGs. So it can take almost 2 years for half the patients to normalize, and the other half are still normalizing their celiac serology. So I remind my patients that I will check your blood work usually every 6 months to see how you're doing, but I don't expect it to be normal usually if you've started super high. Now, the caveat is, if you didn't start super high and now we're sort of at the year mark and it's nowhere near normal, that's another clue to me that maybe you're still getting gluten, because I probably, at 10 months, 50% of those patients should have had normal blood work. So it's helpful to have a little bit of a feel of how quickly the blood work drops depending on how high it was when the patient started. And then the last few slides, I wanted to talk about associated conditions, because that's an important topic I discuss with my patients in the clinic. So first of all, we know that celiac disease does run in families. And so in first degree relatives, they've done good studies looking at what is the prevalence. So how many people have celiac disease if you're the sibling. So I usually quote 10 to 15% for siblings. That was sort of the same rate that I showed you before about the fraternal twins. It's about 10, 15%. If you are the child, so if your parents have celiac, the rates are less than that. And then if you're the parent and your children have celiac, the rates are even less. We more commonly see celiac in females over males. I presented to the family that based on these statistics that studies have shown, about 85% in the first degree relatives, you're not likely to have celiac. So in many families, it doesn't make sense for everybody to go gluten-free, because everybody will not likely have celiac disease. But it is absolutely recommended that all first degree relatives have a celiac screen. Anybody over 3 years of age, or if they're younger than that, but have symptoms. And then this part, there's not specific guidelines yet, but I usually say repeat the screening every 3 years in relatives if they're asymptomatic, and obviously sooner if they have symptoms. Celiac can be associated with other autoimmune conditions. So the most common one is thyroid issues. And so I screen for thyroid at the time of diagnosis and usually every year to 2 years. Psoriasis has high rates in patients with celiac, though I have to say in pediatrics, I don't really see many patients with psoriasis. Of course, we talked about type 1 diabetes, and then Sjogren's is a condition with very dry eyes and mouth. So this is a document that I have taken off the Canadian Celiac Association website. If you to find this document, in the search field, I think I put management, or it's under management under professional resources. So here it sort of outlines all the elements that a family doctor should sort of go through in following patients with celiac disease. And then there's a nice chart here going through what should be done at diagnosis, and then at the first few visits in the first year, and then on an annual basis. So that's a really good reference. And I print this out for my patients who are turning 18 so that they can make sure that their family doctor is quite aware of what should be done. And at minimum, it's generally getting measurements of height and weight, as well as doing the celiac serology every year, and then the thyroid screen about every 2 years if it's been normal. So to summarize, for the diagnosis part, really the TTG is the best test. That is the test you want to start with. There are so many tests that the lab may offer you to do, but really this is the best test to start with. There may be some children who qualify for a diagnosis without a biopsy, like I mentioned. And then in follow-up, really some of the key factors are making sure the kids eat enough fiber, have vitamin D supplements, eat enough calcium or take a supplement. And then if your symptoms don't go away on a gluten-free diet, then really talking to your doctor to try to understand what could be those contributing factors leading to that. And then of course, point number 7, really, it's so important that patients starting on a gluten-free diet meet with a dietitian who's very familiar with a gluten-free diet. And then also have some periodic follow-up as well. As children grow older, their diets change. When they're 5, they may have certain foods they eat, and as they grow older, their diets change. So I try to get my dietitian involved with the patients at their visits, or certainly offer them that, because they can certainly, what they eat can be different. And there's some really excellent resources on the CCA website, whether it's the gluten challenge document, the other one I just showed you about management and follow-up in patients for a family physician. So excellent documents that you can go back to. So I wanted to stop there. I hope it is a bit of a run through I've given you, but I hope I have answered some questions through some of the topics I've covered, probably raise some questions as well. So I'll leave it open to what questions we have right now. Oh, and this is Moraine Lake. That was Moraine Lake in Lake Louise, so it's beautiful.
And it's a beautiful picture. Thank you so much, Dr. Dominica. It was an amazing, comprehensive overview. I am sure it was immensely helpful for everybody. Please also make sure to join our CCA moderated Facebook group, sign up for the newsletters and alerts, and check out our YouTube channels for past information. If you've enjoyed tonight's presentation, please consider making a donation to help us continue delivering programs and services. Please visit the www.celiac.ca and click on the donate button. You will receive a link to an evaluation, and you should let us know how we did tonight. We hope you to complete it so that it can help improve us and also offer us suggestions and topics you would like to hear more about. Now, on to the questions. I am going to read out the questions. So where are my questions? There they are. Okay, so first question, Dr. Dominica. I have celiac disease and my infant has started consuming gluten. What kind of signs should I be looking for at this early stage since she is not yet vocal?
Excellent question. Before I answer that question, I just also wanted to address the whole question about infants and gluten intake. There was a lot of research looking at how we can potentially modify the risk of developing celiac disease in first-degree relatives. There was an excellent study released a year or so ago, looking at the amount of gluten that is offered to very young children. So that study did show that the larger amount of gluten that children ingested, that those children more likely develop celiac. But we've also seen studies that showed that if you delayed gluten, it did not make a difference. So my recommendation, and just sort of not yet answering your question in general, is if you have an infant and you have celiac, that giving them a variety of grains with some gluten, but trying all the other grains as well, and not giving them large amounts would be what would be recommended right now. So when it comes to this really early stage, so the first thing, so I really have hundreds of patients in my practice with celiac, and the youngest patient I have diagnosed, or who I follow, in fact, she was, I think, diagnosed even in Europe, was 18 months. So I have not seen anybody really diagnosed much younger than that, because there is this process of having to ingest gluten, the intestines being inflamed, and then that causing enough symptoms. So that's the first thing, is that I think there's a bit of a process that needs to take place, and usually that's the earliest I've seen. The symptoms in kids can be variable. Gosh, I've had somebody do celiac screens because they're cranky kids, because they really can't express how they feel, but they're just cranky. They don't feel good. They're tired. Kids can be like, kids nap, but you might find them less spunky. Some kids have really loose stools. That needs, there's a whole list of possibility when kids have loose stools, but some of them have loose stools. Sometimes their belly can look really bloated, really stretched out, so they can have bloating, loose stools, crankiness. I've had some kids with more thin hair, so just not having too full, like young infants don't have necessarily full hair, but those are some of the symptoms. And if you're worried about whether your young one has celiac, I would suggest thinking about a celiac screen if you're worried sort of around 2, or if you don't have any symptoms that you can see, then we suggest all relatives should be screened when they're 3 years and over.
Thank you. Next question. Is it possible for the intestinal walls to repair itself over time with a gluten-free diet or through supplements such as glutamine?
Not the supplements, but yes, over time, the intestines will heal. In fact, your intestines are always regenerating. But in the case of a patient who has celiac and eating gluten, that regeneration can never fully take off because they're always being inflamed by the ongoing inflammation. So as soon as that inflammation stops, the intestines that are always regenerating can finally grow, and the villi can regrow. In pediatrics, they've done studies that usually around 2 years after starting gluten-free diet, the children have normal intestinal villi, and if they're on a strict gluten-free diet. So we know that the intestines can heal and repair itself on a gluten-free diet.
Okay, so next we have 3 questions in one. I'll read out the first one. Can you share some of your thoughts and understanding about the link between celiac disease and stunted growth in children?
Excellent question. That is a symptom that we, like a sign, or that we certainly look for. So when you see a patient and sometimes I don't have a growth, many plots on a growth curve to go by, but their weight and their height are disproportional. So you wonder about stunted growth. The idea, because we see stunted growth in other conditions such as Crohn's disease as well, when your intestine cannot absorb your nutrients, you will have stunted growth from that perspective. Also, the inflammation in your intestine can affect the growth hormone and how that's released, and so the children can have stunted growth. So there is some good physiologic explanations for that, and I have certainly seen young children in my practice who weren't growing as well, and then after starting the gluten-free diet, their growth improved. Now, what I typically see, first of all, we don't see as many kids with stunted growth now, because I think people think about celiac disease faster before the kids get stunted. But what I typically see is if the child has been underweight and they go gluten-free, the first 6 months they're finally regaining the weight that they'd lost, and then usually sort of over the next 6 months to the year after starting gluten-free diet, we might start seeing their growth improve. So in terms of their height, I don't usually see that improve right away. It takes some time over the 6 months, a year, 18 months after going gluten-free that you start to see their height trajectory improve.
By what age is diagnosis needed to get a good recovery of growth? And is there an age where full recovery is not likely?
Also, excellent question. So, for the question about what age do you need full recovery of growth? So, teenagers, at somewhere around when teenagers are going through the growth spurt, if they are very active in celiac disease at that point, they may not have an opportunity to fully recover their growth. One of the reasons I also don't do I also try to do a gluten challenge if we're thinking about it before the child starts entering puberty, because then we know that we can certainly recover their growth with the intestinal healing. So I mean, when I read into this, I make the diagnosis as soon as we try to think about it. As soon as a child presents with symptoms, that you try to make the diagnosis right away. And if you have most children present sooner than adults. Adults may go decades undiagnosed, and most children, because they would stop growing with celiac, get diagnosed much sooner, and therefore they have less impairment of their growth because they don't go 10 years without being diagnosed, because by then somebody would have picked that up. So, and then the last question, is there an age when full recovery is not likely? So in children, we see good recovery. In adults, they have seen that about a third of adults don't recover completely their intestines. So there is some continuum between being a teenager and an adult. And again, many children get diagnosed much sooner than some adults. And so therefore they don't have the intestinal inflammation as long. And so most children, especially would recover within 2 years. We don't biopsy even after they start a gluten-free diet to document recovery, because we know they recover. So it's more the adults that they worry about not having full recovery.
Next question. Why can some children be asymptomatic and still have celiac disease?
Oh, that is a really, really good question. It is also one that I struggle with in my practice, because many of my asymptomatic patients who don't also have symptoms when they gluten struggle sometimes. And the other sort of other point to this is, so many of the patients who have type 1 diabetes and celiac have no symptoms of celiac. It's a very large group of them have no symptoms. I think in this case, everybody has a different threshold to what type of symptoms they develop. I think some children may have bloating, but be so used to it and not really express it as a concern. Some children are asymptomatic, but then after they go gluten-free, in fact, report improved energy. They didn't even realize they were tired until after they went gluten-free and realized they had more energy. So sometimes there's symptoms that develop sort of that you look back and you think, oh, those are my symptoms. And some children truly are asymptomatic. I've scoped so many children and who don't have symptoms but yet have intestinal inflammation, maybe redness in their duodenum. And it's shocking to me as well. And I don't know if they've gotten so used to how they feel that they don't even realize it's different.
Okay, so next question. Was there COVID considerations to discuss?
So what we had done, well, I'm not entirely sure what this question directly refers to, but what we had done during COVID is we were postponing scopes. Actually, I think I know what you're referring. Like if we also, so we were postponing scopes during COVID because we couldn't scope them. And many patients we told to go gluten-free, and then we were going to do a gluten challenge now that we're scoping again. The other topic is, what if a patient with celiac disease has COVID? And so because celiac disease is an autoimmune condition, but it is not an immunosuppressive condition. So it is not the same as patients who are, for example, on prednisone for an immunosuppressive condition. So our recommendations for COVID have been the same as public health. So that patients do not have a higher risk of developing severe COVID disease than what is the risk based on their age and other medical concerns that might put them at risk.
Okay. Um, my son got diagnosed with celiac 6 months ago. He is IgA deficient, so the TTG test is not applicable. How to know if he is healing? His symptoms are much better, but he still has symptoms. How to know if he is healing?
Okay, excellent question. I have many patients with Ig deficiency too, but there is a celiac screen that can be done in those patients. It is the IgG TTG. So IgG is a different type of antibody, class of antibody. It can be measured in patients who are IgA deficient. What patients should know is it takes much longer to go to normal than the IgA test. The other test that can be done in this group of patients is an IgG DGP. So DGP stands for deaminated gliadin peptides. So there are actually celiac screens that we can do in IgA deficient patients. Sometimes in certain labs, they have to be specially ordered by the doctor. Sometimes they are done automatically when the IgA is low. So in patients, so that's one way to know that he's healing, is that the numbers would continue to improve every 6 months that they're repeated. If a patient continues to have symptoms, for example, and we're 2 years out on a gluten-free diet, they still have symptoms, and especially if their TTG is very, very slow to improve, sometimes they do need an endoscopy to show that they've healed. So there's a few patients that I have scoped 2-3 years after starting gluten-free diet to demonstrate healing.
Can you recommend a gluten-free multivitamin? My daughter is 8 and she is a very picky eater.
Oh, I should have a gluten. I get this question often, and I usually defer it to my dietitian, in fact. So I'd have to ask her if I don't know, Gauri, do you have a special gluten-free multivitamin that you might recommend?
No, not
No.
usually.
No, I think some of my patients take Jameson brand. The sort of important things on what is in the multivitamin to read about is, does it have some folic acid? Does it have some thiamine? Does it have some B vitamins? Usually the answer to all of those is yes. And then most multivitamins will have vitamin D, but it won't be enough usually. So maybe some of you who are living in Southern Ontario or Quebec, who have more sunshine than us in Alberta, may not need 1,000 units of vitamin D, but most of us sort of here in the longer winters, that's how much we need. So you would need extra vitamin D on top of the multivitamin.
Okay. So, if a child has celiac and the parents are negative, can the parents still develop celiac later in their life?
Yes, yes. Most of the time what I see is that everybody gets diagnosed around the same time. One patient in the family gets diagnosed, everybody else gets screened, and surprisingly, other people get diagnosed even if they don't have symptoms. But I do ask the parents to have their celiac screens done every 3 years, because they could develop it. Because we know that most likely the genes are in the family, and then there's a trigger that turns on that inflammation and causes those T cells to start reacting. So that could happen in a patient who has the positive genetics for celiac at any time. So I suggest repeating the celiac screen every 3 years to see.
Mhm. Any advice for a high-level endurance athlete, 17-year-old female cyclist, given the stresses of training and competition as well as being celiac?
Mm.
Thank you.
Oh, excellent. So these patients really need to work with a dietitian, because they need to eat high caloric foods, because they're burning so many calories. So for example, being vegetarians would be difficult because they would need to eat a lot. So in those cases, I think the big one is working with a dietitian. So I don't take on that specific issue myself, but I really, really get my dietitian involved. So in those cases, we might do a calorie count, try to estimate how many calories they burn, so what their caloric needs are, and then try to understand on a 3-day calorie record, are they meeting those requirements? So I don't have a very good answer for that excellent question, simply because I do send those questions off to my dietitian to help work with the patient.
Okay, so next, can children outgrow celiac? I know kids can outgrow allergies. Is it the same for celiac?
So no, and that's when in my one of my initial slides I showed those CD4 T cells that are sort of primed to react to the deaminated gliadin, and we don't know how to turn off those T cells yet. So your intestines can heal, but those T cells are still hanging around, ready to attack if somebody eats gluten. So no, children do not outgrow celiac, and celiac is not an allergy. So in patients who have, let's say, a peanut allergy, they have a completely different immune response than what we see in celiac. Those allergies are what we call IgE. Those are completely different types of immunoglobulins and cells that are reacting. So a celiac is not an allergy, and so it's a T cell mediated response, and we do not know how to turn off that response. So we do not know how to outgrow it. There's research looking at how do we maybe try to turn off the immune response. We don't have those answers yet, but there are studies and people are looking at how to do that.
This is a question which I also get asked very often. My son got diagnosed with celiac and is IgA deficient. The doctor is trying to see if there are other members of the family who have celiac. My daughter, who is 5 years old, is IgA deficient as well, and the lab does not want to do a IgG DGP test. She's also iron deficient. Are her chances of celiac disease very high? Is biopsy the only way to confirm or rule out celiac disease?
Um, so the IgG-TTG is a test that should be done by every lab. For me, even in Calgary, if I want to do the IgG DGP test, it's a special request to the lab to do that. So I can understand how the lab doesn't automatically do that. I send a special request to the individual in our lab who runs the celiac screens on specific patients to run it. So the IgG TTG could be done. In patients with IgA deficiency, there is a higher rate of celiac disease that we know, and some of those patients should have, like many of those patients should in fact have a biopsy to decide if they have celiac. And if the child eats well but has iron deficiency, then maybe doing the IgG TTG and considering a biopsy and discussing that with the physician would be important.
How common is it for a child with Addison's disease to develop symptoms of celiac disease when other siblings have celiac disease?
Hmm. Um, Addison's is not one of the more common associated conditions with celiac, but being autoimmune, it you certainly could have the genetics overlapping. How common is it for a child with Addison's to develop symptoms of celiac? So in that case, I would say, the 10 to 15% rate of celiac that I typically quote in siblings.
Okay. For parents of children with celiac disease, where one parent had family with CD and the other parent does not, should both parents be screened as first degree relatives every 3 years?
Yes, yes, I think so. The TTG is such a simple blood test to be done. It can be added to an annual screen. It is reliable, inexpensive. And although I've heard this, that, some families say it must have come from this end. Look at everybody who has thyroid issues or somebody else. But really, celiac disease is common enough that I think all relatives should be screened. The other reason to screen both parents every few years is most households eat less gluten when somebody has celiac. And so some like the parents, for example, might have minor symptoms because they're not eating as much gluten, for example. And so that celiac screen would be important to know if there's anything that's changed.
Okay. Should all pediatric patients be followed by a gastroenterologist, or is follow up with a family doctor sufficient?
I think an excellent family doctor who who offers regular follow-up with a patient is excellent. Certainly the diagnosis is made by a gastroenterologist. Often the first few follow-up visits are with a gastroenterologist and seeing a dietitian. But if there's, not a gastroenterologist around that's seeing patients regularly for this, then the sheet that I showed you from the CCA website is an excellent sheet to bring to a family doctor and say, okay, I have celiac. Here are all the things that the Canadian Celiac Association recommends that patients with celiac disease have done through their family doctor. And so I think the important thing is that a patient has regular follow-up on an annual basis, regular blood work annually, and if they have any questions, that they have access to a dietitian to address those.
Is there an age where kids are more likely to be diagnosed with celiac disease?
No, I have probably 25% of my patients with celiac disease in my practice are under the age of 6. Of course, I have a lot of them around 9 or 10, but they span the whole age range of pediatrics. So I see all the ages.
My 17-year-old has had a little follow-up since diagnosis at 7 years at ACH. Good compliance, but plagued with low ferritin levels and acid reflux as a teen. Should she get a final follow-up at the ACH before she ages out of peds?
Yeah, so yes, we do recommend that if that we see the teenagers again, especially to talk to them about their understanding of the gluten-free diet, so that they understand what follow-up they need. Yes, so I think that is certainly worthwhile. The timing of that is hard to predict when that will happen. There's dietitians that they could sit down with to answer their questions, and definitely having regular blood work would be important, like a celiac screen, uh, just before their visit, so that the physician can know where they are at if their celiac screen is normal.
Okay. What are the risks, if any, to going on a gluten-free diet just to support other family members, even though not celiac oneself?
What are the So the risks are sort of that first nutritional slide that I demonstrated. So the gluten-free diet can be low in fiber, can be low in folic acid, B vitamins, and especially concerning can be if patients eat more processed foods. So it can be very high in simple sugars and fats. So they've done some studies in adults to show that in fact when they take the adult's cholesterol, blood pressure, weight at the time of diagnosis of celiac disease, and then a year later on a gluten-free diet, many of them have gained weight, their cholesterol has increased. And so in celiac patients, the gluten-free diet is medically necessary. But if somebody doesn't do it right, they could actually uh, eat unhealthy. So that would be the risk, is that potentially the other family members, because it's an expensive diet, if everybody eats healthy, that's okay. And if they eat a variety of foods, but the potential is if they eat too much, that the foods have too much sugar, high in fat, low in fiber, and folic acid and thiamine.
One last question. Are there other types of tests that should be done as a late teen?
So patients with celiac disease should have a thyroid screen, every year for the first couple of years, and then every few years if it's been normal. So the teen should have the thyroid screen, the ferritin, the calcium, the ferritin, the CBC, the celiac screen to see how it is, and to get a full profile. I don't typically do, like I said, the bone mineral density unless the teenager is really not adherent to the gluten-free diet. They have no symptoms. They don't really know why they should do this. So I try to show them that maybe their bones are suffering. But other than that, there's no other specific tests that the teenager should really have if they're otherwise asymptomatic and doing well on a gluten-free diet.
Mhm. And what are your thoughts on oats?
Oh, very good. Um, the CCA has recently written up a statement on oats. So I think gluten-free oats are very important part I talk about it in my pediatric patients because they're excellent source of fiber. In the diabetic patients, there's a good source of carbs that are slow release. They're not super high sugar, so very good source of fiber and nutrition. They must be gluten-free, and very rarely do patients react to it. So right now, previously we used to say, wait till you introduce oats for a year or 6 months after going gluten-free. And that's changed a bit now. And now we, sort of talk about oats early on because there's a lot of good nutritional value in them. They have to be gluten-free because regular oats are cross-contaminated, like up to almost 90% of them. And that is sort of one of the reasons why regular cereals, such as, some Cheerios or other cereals that don't source gluten-free oats, are not gluten-free.
Dr. Dominica, I'm going to take one last question, and I think this is a question that weighs heavily on a lot of people's mind.
Mm.
When we go on vacation, my daughter often gets contaminated despite all our precautions. What are the consequences of that, especially in the long term?
So it is a very good question. And the first image I showed you of that complicated sequence of events that happens in the intestines, if somebody eats gluten briefly or for a very short period of time, their intestines will not all be flattened by that process. Yes, there may be some inflammatory proteins that come to the intestine. Some T cells are more activated, they release cytokines. But then when the gluten is eliminated, because they either return back home or not every meal is contaminated on vacation, then that process stops. And it's not this self-perpetuating process that happens. You need to be eating gluten for that process to be occurring. So the reality is, yes, people need to travel. They do the best they can on a gluten to maintain a strict gluten-free diet, and there will be occasions where they might be cross-contaminated accidentally, but the long-term consequences when they're overall staying on a gluten-free diet is that they will do very well.
I think these are most of the questions. And if there are any more questions, feel free to email them to me at clientsupport@celiac.ca or at info@celiac.ca. It's even available on the website. As for the oats, we have a whole statement on the website. Please go ahead, read it. If you have questions and concerns, email, call us anytime. And now I would like to definitely say thank you to Dr. Dominica for such an awesome presentation. And this was awesome information.
Thank you for inviting me. I really enjoyed this. Thank you everyone for asking such excellent questions. They come up often, and thank you for asking them.
Thank you, Melissa, our director, for being with us here. And the sponsors were Udi's Gluten-Free and Glutino, who helped us host this session, this very good education session today evening. I wish you all health and happiness. Stay safe. Good night.